So before we start officially with this session, I would like to give a brief introduction of Dr. Tuba. So Dr. Tuba is a graduate of Alama Medical College, Lahore, and she completed her medical residency from pediatric residency from Atrium Nevisant Health in Georgia. And she's currently a fellow of Pediatric Emergency Medicine at Children's of Alabama, Birmingham. Okay, so welcome, Dr. Tuba. This session now.
Okay. Assalamualaikum. I'm Tuba. The topic for my talk today is the cardiac arrest and the high quality CPR in the pediatric population. So the cardiac arrest occurs when the blood circulation ceases because of the ineffective cardiac mechanical activity. What to look for in a child clinically, the child will be unresponsive and not breathing or just agonal breaths, and there is no pulse. Cerebral hypoxia causes the child to lose the consciousness. So you might see some breathing, but that's not like true breathing. When the circulation stops, the resulting end organ and tissue ischemia can cause the cell organ and damage and the patient death, if not rapidly reversed. So the pathways to the pediatric cardiac arrest. What leads to the cardiac arrest in the pediatric population? Not the cardiac causes in the first place, for the most part. Most of the time, it is either, for the most part, generally, the respiratory distress or failure leads to the cardiac arrest, or second cause would be shock, and that would lead to the cardiorespiratory failure and eventually cardiac arrest. Sudden cardiac arrest because of the arrhythmias is relatively uncommon in peds. Highlighting some reversible causes of the cardiac arrest. We call it like H's and T's. So with the H, it's hypovolemia, hypoxia, acidosis, hypoglycemia, hypo or hyperkalemia, or hypothermia. The T's are tension, pneumothorax, cardiac tamponade, toxins, or thrombosis, pulmonary or coronary. Okay. Next is managing the cardiac arrest. Your first step is to verify the scene safety, make sure the environment is safe for the rescuers and the victim. Next is, how do you recognize the cardiac arrest? First, check for the responsiveness. Then, if there's no breathing or only gasping, and then no definitive pulse felt within like 10 seconds. And you usually check in the brachial or the femoral in pediatrics. The breathing and pulse check can be done simultaneously. First thing is you activate the emergency response. So if you have somebody like a bystander there, just ask them to call the rescue number, okay? Then in terms of the compression ventilation ratio, if there's only one rescuer, you'll be doing 30 compressions with 2 breaths. If there are 2 or more rescuers, then you'll be doing 15 compressions to 2 breaths. The rate for the compressions is roughly 100 to 120 per minute, and you'll be giving 1 breath every 2 to 3 seconds. So that makes a total of 20 to 30 breaths per minute. Compression rate and depth. The rate, as I mentioned earlier, 100 to 120 per minute. For the depth, at least 1/3 of the AP diameter of the chest. So in the younger infants, it would be 1.5 inches. That's like 4 centimeter. And in children, it's going to be close to 2 centimeter or 2 inches or 5 centimeters. Position for the hand placement. In the infants, if there's one rescue, 2 fingers or 2 thumbs in the center of the chest, just below the nipple line. So you're going to press like this. Okay. Mm-hmm. And 2 or more rescuers, 2 thumbs encircling hands in the center of the chest. So you'll hold the baby's chest like this, and then you press with your thumbs, both sides. Okay. In children, 2 hands or 1 hand. If it's a small child, you can use 1 hand, but mostly you'll be using both hands.
Okay.
On the lower half of the sternum, as shown in these pictures. It's important to allow the complete recoil of the chest after each compression, and make sure you do not lean on the chest after each compression. You know why is that important? The recoil?
You
for
may
the
stop
heart to
the blood flow from coming from the heart.
yeah, to refill the heart, yeah, doing diastole.
Mm.
Okay. Very important to limit the interruptions in the chest compressions to less than 10 seconds. And then that's the number they calculate for the efficiency of the, like, how good is a CPR, and that number, the chest compression fraction goal is 80%. Another thing to look for is what rhythm disturbances can be with a pulseless child. So if the child does not have a pulse and is unresponsive, these are the four possibilities. It can be asystole, it can be PEA, that's the pulseless electrical activity. It can be VFib, ventricular fibrillation, or pulseless VTAC, pulseless ventricular tachycardia, and that includes torsades as well. This is asystole. Like, I'll go over the algorithm later, but just to give you guys a brief view of, like, once you put the patient on the monitor, what you look for and how do you interpret that rhythm. So ACC can be just a flat line, or there can be some random small electrical activity, but that does not count. Basically, that is asystole. Pulse activity, that basically is like, it can be any rhythm, doesn't matter what rhythm it is. If the patient does not have a pulse, it is pulsus electrical activity. Okay. Ventricular fibrillation would present like this on the monitor. And then this is VTAC. VTAC and without the pulse. That's the cardiac arrest algorithm. Make sense?
Just one question, Dr. Mansoor.
Yes.
You talked about pulsus electrical activity versus asystole. So on ECG, how would they differ?
So pulsus activity can still have a rhythm,
Mm-hmm.
but the patient won't have a pulse.
Okay. Okay.
It can be sinus tachy,
Hmm.
but the patient won't have any pulse.
Okay.
Okay. And the pulses, so VTAC on the monitor. If the patient has a pulse, you go with a different algorithm, versus if the patient does not have a pulse, then you go with a cardiac arrest algorithm. Does that make sense?
Mm-hmm.
Okay.
Yes.
In terms of the vascular access, the options are IV access, IO, and the last would be endotracheal. Do you guys do IOs there?
We do not.
Do
We
not.
haven't
Okay.
practiced it.
Okay. Okay. So if they're like at least twice, if you have already tried in a coding patient to get the IV access and you're not able to, so just so as you have some sort of access, we like to put intraosseous. That means you basically drill in the bone, and you can either do like manually, or it comes with a drill machine too, and you can drill it. It's pretty easy. And the specific points on the body where you can do it in pediatric, usually around the knee. So proximal tibia or distal femur, or the distal tibia, medial distal tibia. Those are the three mostly used like areas where you can put IO. Okay. And you can almost give any medication through it. You'll basically use it as an IV.
Is it very painful for the patient?
So this is a coding patient, so you don't worry much about the pain. The other thing is, you can, if you're doing it more in like in a control environment, you can use local lidocaine too.
Okay.
Yeah. And you can start fluids, you can start medication. Meanwhile, you still try to get an IV access, but you still have some like access to give resus. Okay. So this is the algorithm that I was talking about earlier. This is the pediatric cardiac arrest algorithm. I give you a brief overview of like a background of what components would be on this algorithm. So if you look on the top, you found the patient unresponsive, not breathing, does not have a pulse, you start a CPR. If the patient is in the hospital, the first thing would be to put on the monitor. You're going to check the rhythm. If the rhythm is shockable, so like we just talked about, 4 classes of rhythm. The shockable ones would be VFib or pulseless VTAC. Asystole or PEA are not shockable. So you would know like which way to go the next step. If the rhythm is shockable, that means it's a pulseless patient and the rhythm is either VFib or VTAC. You need to defib the patient. So remember, VFib, defib. You need to use that defibrillator. Okay. And on the side, it does tell you the dose, like what to use for the defibrillator. The first shock would be 2 joules per kg. Second would be 4 joules per kg. Okay, just like to have an idea. If you're going this route, you'll shock the patient, you resume the CPR. You do it for 2 minutes. You again assess your rhythm. You shock, if it's still shockable, you shock it, resume the CPR. So that way you go down. If say it's asystole on the monitor, or if there is some rhythm, but the patient does not have a pulse. So that means it is not shockable. So then you go this route and then you'll do the CPR. So it's basically cycle of CPR, epi, CPR, epi. Okay. So you'll do CPR for 2 minutes and then you reassess. Epi can be given every 3 to 5 minutes. To make things easier, what we do is we do epi every 4 minutes. So in 2 minutes, you do CPR for 2 minutes, you check the pulse. You do CPR for another 2 minutes, it's time for check the pulse again, and then you give the epi dose with it too. So with every alternative pulse check, you're going to do a dose of epi. Does that make sense?
Yeah.
Okay. Yeah. And that's also like to minimize interruption in the chest compressions too. Okay.
Right.
And on the side, it does give you, as I said earlier, defib doses and the drugs. If you have tried epi a couple of times and you won't move, you can. The other options on this algorithm is amiodarone or lidocaine. So you might end up doing that too. Okay. You can intubate the patient, but to look for like intubation, that would be like the same time, like you're pausing for the pulse check, to intubate, to give the epidose, whatever needed, like together. You cannot like pause the chest compressions and do intubation. Like you cannot make like long pauses. That's the main thing. Okay. And then these are the same HNTs. That meanwhile, you'll still get the baseline labs and then try to see, like, check the patient's blood glucose, if it's hypoglycemic, or the temp, or get the blood gas. What does it look like? So anything that can be corrected, you treat it accordingly while you are doing your algorithm. Okay. I think that's all on it.
All right. Thank you so much for that, Dr. Mansoor. Go ahead, Werda.
Yes, okay. Thank you so much. Does any of the participants have any questions?
Hello, Assalamualaikum.
Okay.
So I have a question that the flowchart that we just saw, is it for when the patient is at the hospital, and what are we supposed to do if we don't have a monitor? So we're just going to continue CPR for that time?
Yeah. In the field, you'll continue to do the CPR, and depending on if there's like one rescuer or two, that would be your ratio, different ratio for the chest compressions to the breaths. But you'll continue the CPR till basically the help arrives.
Okay. Okay. And I have another question that you've just talked about pulseless electrical activity and pulseless VTAC. So can you please explain the difference between the two and
So the VTAC, that particular rhythm, like specific for VTAC, is like wide complex tachycardia. If you see that one and the patient is pulseless, so that's going to make it pulseless VTAC, and then you shock that patient. But other than that, like sinus tachy, sinus Brady, or any other rhythm would be classified as PEA.
Okay, thank you so
That's pretty
much.
similar to what we practice in adults as well.
Okay, that's good. Yeah. And if it's like with a pulse, then the tachycardia and the Brady, those are different algorithms that I did not include in this presentation. Yeah.
Okay.
Because the most common tachycardia with a pulse that we see in pediatric population is SVT. Have you guys seen SVT?
Yes.
Yeah.
Yes.
So that's the most common one. Yeah. From the other algorithm. Yeah.
Okay, so Dr. Duba, I have some like different questions. You have already explained the topic really well. What I wanted to know was like, what are the other pediatric emergencies that you face in in real life in your fellowship?
Okay. So thinking from head to toe, closed head injury, non-accidental injury, non-accidental trauma would be like child abuse,
Okay.
seizures, status epilepticus, talking about the respiratory asthma, acute viral bronchiolitis, then congenital heart diseases. In the newborns, newborn sepsis, newborn fever / sepsis that comes in the same. What else? Broken bones, lacerations, foreign bodies, like any kind of like, it can be like very small, like not so emergent, to like level 1 trauma.
Is there any case that resonated with you?
Like
some case that was very memorable for some sort of reason?
a lot of cases. I think new onset diabetes are some like, they usually present in DKA. Those are the ones that, you'll kind of like remember because you diagnose them. Brain tumors, any other like leukemia. Those would be the cases. Or if any, of course, any patient dies, I think I probably remember all of my patients passed away, did not, or the coding patients that you like see in the resus bay. Those are like hard to forget, and then difficult to have conversation with those families too.
How do patients with leukemia present in the ER?
Depending on for how long it's been going on. I had recently seen 2 patients in the past week. So one was like long history of being very pale, long bone pain, some like just non-specific symptoms, have been sick off and on, and then petechiae that made them go to the primary doctor, and they did some like basic CBC, and then white blood cell count was very high, platelets were very low, and the patient was anemic too, so sent to the ER for further workup, and then we did some baseline labs and consulted hematology and have them admitted. Or some would be like just like some minor injury and they're complaining of bone pain, and it just happened to be like, oh, we got the x-ray done and then they see some bone lesion, or we did the CBC and they saw the blast on the peripheral smear, and that's how it was diagnosed. So it depends.
All right, so if anyone doesn't have any questions, I'm just gonna switch gears and ask about your fellowship and how you got into that. So does anyone have any questions? All right, Borda, go ahead and ask Dr. Tuba, how did she start her fellowship? How did everything go for her?
Okay, so yes, Dr. Subham, also wanted to know, like, how did you decide that pediatrics emergency was your thing to do?
Yeah, so while I was doing my GNP's residency towards the end, I realized like I like inpatient and ER the most. So then I was trying to decide which way I want to go, and I felt like I enjoy ER more than the inpatient. So that's how basically I decided. And towards the end, like you have some optional rotations that you can like put some extra time in the field that you're actually going to work in. So I did some extra ER rotations too. So that was like a good basis to start working in the ER.
Okay, so actually, pediatrics itself is considered overall a very rewarding field, right? So do you think the same about pediatric emergency? Like, does it have great prognosis overall?
Yeah, I mean, there are going to be pros and cons for every field that you go to. The good things about ER in terms of like for your lifestyle is you do not have to go to work every day, right? So that's a big plus. So you do shift work, okay? But at the same time, the shifts are so variable. One day you might be working in the morning, the next day you might be working an overnight shift, and then an afternoon shift. So it's not like consistent schedule. So you have to move things around that schedule, okay? In terms of the patient, I mean, I like working with high acuity patients. So I like seeing trauma, I like seeing resus, I like procedures, I like to do sedation, laceration repair. So all that stuff, if you like that hands-on kind of experience, you're gonna like ER. Okay. But at the same time, as I said, like if you're doing a code, patient did not survive, or you're diagnosing a patient with a chronic illness or like cancer, that's going to be hard on you and on the family, on everybody. Right?
Great.
Yeah.
Okay, so
All right, so I think you did tell us about this, but how long would be the fellowship for emergency medicine if we go through peds, and then how long is it through just emergency medicine, like
Right.
adult?
Yeah, so I did general pediatrics residency, that's 3 years. And then after graduating from the Gen Peds, you do 3 years of pediatric emergency medicine. But if you choose to do just like adult emergency medicine residency, then you decide to get some more experience in pediatrics emergency, because no matter where you work in the emergency, in the adult emergency, you'll still see some pediatric patients. So some people, they want to get more experience in pediatric emergency specifically, so they go for this fellowship, and for them it's 2 years.
All right. Are there any specific pros and cons to this field that you would like to tell us about?
I think what I just talked about, like, the shift work I like.
Yeah.
You will be working weekends. Some weekends will be off. Same with for the holidays too. Everybody has to take turns. If you're working Thanksgiving, you're probably going to be off Christmas, or if you're working Christmas, you're probably going to be off New Year. It's you don't bring any work home for the most part,
That's right.
because it's not like you go home, you have to recheck the lab, you're following up in a few hours, how the patient is doing. Well, for the most part, once you're done, you're done. But when you're at work, you're seriously working. You work hard.
How long are the shifts? You talked about like sometimes in the morning, sometimes in the afternoon.
So most places have 8-hour shift. Some places have 12-hour shifts as well. I've done 12-hour shifts before too. But right now where I'm working, it's 8-hour shift.
So do you work alternate days?
It's not a fixed schedule.
All right. And
Roughly, I would say maybe 3 days a week or so.
3 days a week. All right.
Rough, but it can be like you have like 4 days straight and then you have 4 days off. So
So we've talked to a few pediatricians who've discussed the money that we receive for our work, and how in pediatrics it's more of you work hard, but you don't get the amount of pay that you should be getting. So do you think this is an issue that's in pediatric ER emergency care as well?
pediatric emergency is a pretty well paid field among the pediatric subspecialties, I would say.
Okay. All right.
Most important thing is I think you should like what you do, so it doesn't feel like going to work every day.
Right.
That's most important, because if you like your work, then you're excited to work, and you enjoy it. No matter, some days are gonna be harder than other, but then not all days are gonna be that way, right? But if you do not like what you do, then it's just like you're pushing yourself to go to work, and that's not gonna be good.
Mhm. Was it tough to obtain a fellowship in pediatric ER in emergency medicine?
It is competitive,
All right.
I would say that. Yeah.
Do you have any pointers for anyone who wants to go through that route?
Strong research work. My path was a bit atypical. So what I did is like I did Gen Peds residency, then I worked in the pediatric ER
Mhm.
for a few years before going for fellowship.
Okay.
So I did have some good experience that made me a strong candidate, but you don't have to do that. But just like with my family situation, did not want to go right away for the fellowship. So I
Mhm.
chose that pathway. But if you want to be like done, I think
Mhm.
that's a better pathway, like doing residency, doing fellowship, be done with it, and then start working.
Right.
Aim for a good university program.
Mhm.
Aim for a program that has pediatric ER fellowship there.
Mhm.
You can stay in the same program. They know you. Hopefully they like you too. Yeah.
Right.
The program I did residency, they did not have any fellowships. So I had to find a place somewhere else.
Mhm.
Yeah, research, good recommendation letters.
So
Uh,
you talked about research. How can someone get involved in that? I know we are medical students right now, but
mhm.
what is a good way to start research?
I think depends on your program too, where you do the residency.
Mhm.
Once you start the residency, keep in mind, like, if you're planning for a fellowship, plan early in your residency to do some research with your who's ever attending in that program is involved with the research.
Okay.
That would be the best way to do it.
And the research that you were saying that we should have before we apply for the fellowship, should it be specific to pediatric ER or should it just be in pediatrics?
It's good if it's in that field.
Mhm.
Not, that's fine too.
Okay. So is it common for attendings to have these researches going on, or is it very few people that do it?
If it's a strong academic program,
Mm-hmm.
usually they have good research.
All right. And then
Another thing is like you can go for the conferences during your residency. Like
Mhm.
those are related to your ER. Like I went to a conference that was for like difficult airway management conference, pediatric difficult airway management conference.
Mhm.
Another one I attended was like the ultrasound guided, like pediatric stuff in the ER. So if you put that stuff in your resume when you're applying for your fellowship, that shows your interest specifically in that field,
Mhm.
and that definitely helps.
How did you get to know about these conferences? Were they happening in your program or?
No, sometimes I Google it. Sometimes I ask my other friends who are in the pediatric ER,
Mhm.
or sometimes just like reading about stuff, and then you come across some like information. Yeah.
Right. And then
The
last
best way to,
question.
I would say, once you start the residency, in residency, you'll probably be like teaching some med students or doing some sort of teaching. Pick up the topics that is of your interest, because the best way to learn is to teach.
Right. All right.
Because that builds your resume for wherever you're applying.
Mhm.
So you'll have like under your teaching, like, okay, you have taught this, 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 this.
Mhm.
So those would be your strong subjects anyways. And that shows you are generally interested in that field.
Right. Okay. And last question from my end. Have you found or do you know many Pakistanis that are pediatric emergency medicine fellows, or are they few? What's the basically how many Pakistanis have you seen?
Not that common.
Mm-hmm.
Generally in pediatrics, I don't come across many Desi people. Most of the people, either like by choice or it just happens to be that they are in internal medicine.
Mm-hmm.
Uh, but once in a while, I do run into like some Desi person who's a pediatrician. So I won't say it's like rare, but no, yeah, less common than internal medicine or family medicine.
Yeah. All right, those are all the questions from my end. Does anyone else have any questions?
I wanted to know, like, what sort of work environment do you have at your hospital, like the sort of team you have, and especially in emergency, you need to, refer people, patients to other departments as well. Like, you need, different calls from different people, from different departments. So how does it work there?
So, definitely we'll be the first ones to see the patient in the ER. And then if the patients need an admission, we consult them, and there's a proper like channel, how to consult, whose service the patient is going to be. Say if it's a known hem-onc patient, then I'll talk whatever workup needed to be done in the ER, we'll do that. And then I'll call the hem-onc person who is on call and tell them, and they'll admit to their service. And it varies from hospital to hospital, but generally it's the same everywhere. There's going to be a inpatient like hospital admission team. There's going to be a PICU like the ICU admission team. And then some subspecialties will admit to their service.
All right. Okay. Okay, so does anyone else have any questions? I think that's it then. Thank you so much, Dr. Tuba, for joining. It means a lot.
Thank you.
Okay. Is that
Thank you.
Let's end the session now.
Yeah.
Okay.
Thank you so much,
Appreciate it.
Dr. Mansoor.
Okay. Thank you so much. Allah
Very
Hafiz.
well.
Allah
Allah
Hafiz.
Hafiz.